Good evening, everyone. On behalf of Concord Biotech, it's my huge pleasure to extend a warm welcome to all the participants. Concord Biotech is a global biotechnology leader in immunosuppressants with strong capabilities in the manufacturing of high quality APIs and finished formulations. With a presence in more than 70 countries, we remain committed to delivering excellence across key therapeutic areas, including rheumatology, immunology, transplantation, and nephrology, with a patient centric approach. So it's our privilege today, once again, to introduce our esteemed speaker, Dr. Vish Prakash Tiwari. A very warm welcome to you, sir. Sir, I think your voice is not audible.
Yeah, now it's coming.
Yes.
Thank you so much.
A very warm welcome to you, sir.
Thank you so much.
As we already know, Dr. Vish Prakash, he is a DM in clinical immunology and rheumatology, and he is based at Indresh Hospital, Dehradun. So we are very pleased to join us, Mr. Dr. Vish Prakash, for the third session in the series of academic webinars. And Doctor, before starting, on behalf of all the participants, we truly appreciate you, sir, for this wonderful initiative that you are taking in this learning of rheumatology. And this is our third session. And with each session, sir, you are creating a very valuable platform for learning, discussion, and clinical advancement. So, on behalf of the entire team and on behalf of all the participants, it's a huge heartfelt thanks to you, sir. And with this note, we can just start the session for today. So, over to you, sir.
Thank you for your kind words. Okay, now we are starting our lecture series, Pharmaco Part 3. Previously, in two parts, screen is visual, na?
Yes, sir.
Previously, last two series, we have discussed traditional DMARDs and synthetic immunosuppressive drugs like methotrexate, hydroxychloroquine, leflunomide, sulfasalazine, cyclophosphamide, mycophenolate mofetil, azathioprine, and and other drugs. Now we are going towards the biological therapies. So before starting this, we have to understand why we are targeting these cytokines or different cells through the biological system. So any drug which manufactured in a biological system is known as biologics. First technique was the hybridoma technique. In hybridoma technique, what they did, they actually fuse the cancer cell, that is a myeloma cell, multiple myeloma cell, to the normal cell, and that brings that cell immortality. So they start creating specific antibodies through the use of hybridoma technology. That is not so much important for us, but that is very important for the basic pharmacology students. So through which technique biological medicines developed, this is a hybridoma technology. Okay. So let's see basic immunology first. Very basics. We will discuss very little things about the cytokines, how it works, then what will be the benefit by blocking all those cytokines. Let's see. First, characteristics of a cytokine. So what is the cytokine? Cytokine is a protein. It's a glycoprotein molecule which interact between the cells. As you know, now cytokines, it's a cyto means cells and kines means the kinetic movement. So it's a communicator. It's a communicating chemical between the two immune cells or sometimes non-immune cells also. So they have different characteristics. So first, we will discuss 11 characteristics of our cytokines. That is very important. First is a pleiotropy. Pleiotropy means single cytokine can affect various kind of the immune cells, such as IL-2, which is a principal amplifier of a T cell, but it can also help in the amplification of B cell, natural killer, and monocyte. So when one cytokine behave similarly in different cells, So they shows the pleiotrophy. So this is known as pleiotrophy. So single cytokine act as a multiple cell type, act on the multiple cell types. Then redundancy. Redundancy means uh, two different cytokines can act as a same cell type and elicit the same response. Pleiotropy means different cell. Then two different cytokine can act on the same cell and can create the same function that is known as redundancy. Such as IL-2 is a can also stimulate the B cell as you know here, and IL-4 can also stimulate the B cell. So this when two cytokines can stimulate the single cell in the same manner, this is known as redundancy. Then synergy. Two different cytokines can amplify or show the additive action such as interleukin 4 and 5. Both are important in IgE production. Similar way, interleukin 1, 6, TNF alpha. All three are important for the inflammation. So suppose you have a interleukin 1. So you have certain kind of inflammation. Interleukin 6, certain amount of inflammation. TNF alpha, certain amount of inflammation. But once you combine all this, you will get more than what is the additive value of that. Suppose each has a unit 5 value. So once all the three cytokines will work together, it will create an impact of 25, 30 like that. This is known as synergy or supraadditive action. Four is the antagonism. So cytokines regulate themselves between them also, such as interferon gamma. It's an inhibitor of IL-4, such as IL-10 is an anti-inflammatory cytokine. So you can simply understand there are inflammatory cytokines, there are anti-inflammatory cytokines. So they can behave as an antagonist also. They can act in a very small amount. This is important. In a very small amount. That's why we need very small amount of the of that drugs, and that even in a millimolar concentration can create a impact. These cytokines have a short half-life. That is there. Why this is a short half-life? God created this short half-life because if it is a long half-life, then there will be an unopposed sustained inflammation to create in the burst form in a short form. That's why there is a short half-life. Then they can act because of the short half-life. They have to act on the local cell that is known as autocrine or nearby the cell that is known as paracrine. Sometimes cytokine also act as an endocrine. Endocrine means ductless through circulation like TNF alpha. It's a pyrogen. IL-6, it can stimulate the CRP from the liver. So through endocrine action, they can stimulate themselves. So this is known as autocrine action, like IL-2 secretion from the T cell that will react on the IL-2 receptor, stimulate the T cell, that is autocrine. Then nearby cell, that is known as paracrine. This is tightly regulated phenomena. So there is a transcription factor. That transcription factor will go inside the nucleus. Inside the nucleus, there will be the transcription. That transcription will lead to the mRNA formation. That mRNA will go to the cytoplasm. Then subsequent protein formation. That means total central dogma. Transcription factor, transcription, translation, protein synthesis. All these processes tightly regulated. Then immune, what are the sources of cytokines? Cytokines produced by the immune cells and non-immune cells both. So after the immune cells, you can see here in even endothelium and fibroblast, even our skin epithelial cells can also secrete the cytokines. And every cytokines have specific receptors. They are different receptors. So 10th point is that they have a different receptor in the different cells. Last, cascade amplification pathway. Same thing what I told you, that is synergy or supraadditive function. They, such as IL-1 can create inflammation, IL-6 can create inflammation, TNF-alpha can create inflammation. IL-1 can augment the secretion of IL-6 and TNF-alpha, and all those things can amplify the inflammation. So that is known as amplificatory action. So cytokines have 11 different type of action: pleiotropy, redundancy, synergy, antagonism. Very small amount is required, short half-life. They can exert action on an autocrine manner, paracrine manner. Synthesis is highly regulated, so transcription factor is also important. They are synthesized from the from different cells, from immune cells and from non-immune cells both, like endothelium cells, fibroblast, skin cell, or epithelial cell. Cytokine receptor is different for the different cytokines, so that is important. So this is for the cytokine characteristic. Now see this, how this cytokines help in different manner. So we have, we have two type of T cells, CD4 T cell and CD8 T cell. CD4 is known as T helper. Then T helper cell help the other cells to create the immune response. So T helper cell can, broadly it is, actually it is nine type, but broadly it is five type you have to know. So in this left side arm, you can say TH1 and TH17. They act on the cellular arm. So one cell we have TH1, one is TH17. One is other side you have a humoral arm that creates the antibody. So T follicular helper cells that create the antibody that helps to create for the generation of antibody. TV helper 2 cell that creates the antibody. So how this T cell differentiate into different kind of T cells? Let's see. Because in RA, TH1 is predominant pathway. Okay, in spondyloarthritis group, such as psoriatic arthritis, reactive arthritis, IBD related arthritis, axial spondyloarthritis, your TH17 pathway is predominant. In your SLE or connective tissue disorders, your T follicular helper pathway is predominant. In your asthma, EGPA, eosinophilic granulomatosis polyangiitis, or scleroderma, your TH2 pathway is predominant. So, if you know which and why how these cells differentiate into all these different cells through the help of cocktails of a different cytokines. They are known as the polarizer cytokines. Okay. So just see, first there is an antigen input. Antigen is presented to the naive T cell through antigen presenting cell, that is macrophage, dendritic cell or B cell. Through the antigen presentation, T cell becomes activated. Suppose this is an intracellular antigen, suppose such as TB, tuberculosis. So TB has an intracellular antigen, that antigen presented to the T cell, then this antigen presenting cell starts secreting IL-2 and interferon gamma. So with the help of IL-2 and interferon gamma, this naive T cell converted into the T helper 1 cell. So what is a polarizing cytokine? IL-12 and interferon gamma. What this is secreting? This is secreting interferon gamma, TNF alpha and IL-2, and that is helping macrophage, that is creating granuloma. Once you create granuloma, you sustain infection of TB. Simple pathway. Once again, TB infection, it is an intracellular bacteria presented to the T cell, and that antigen presenting cell secretes the IL-12 or interferon gamma that convert T naive T cell to the T helper cell. T helper cell secretes interferon gamma, TNF alpha, IL-2, which creates the granuloma. Granuloma contain the Mycobacterium tuberculosis infection. And this pathway is also very important in rheumatoid arthritis. Okay. Suppose you have you have fungal infection, subfungal infection. Fungal antigen presented to the T cell, then antigen presenting cell starts secreting IL-6, IL-23, TGF beta, cocktail of all three. Cocktail of all three convert this naive T cell to the T helper 17 cell. T helper 17 cells secreting IL-17, A2F, IL-22, GM-CSF, and IL-21. Not a big deal. This pathway is important in spondyloarthritis group. So suppose you somehow able to block this pathway, so you will get less TH17. You will get less spondyloarthritis. So what are the polarizer of TH17? That is IL-6, IL-23, TGF beta. Remember IL-23. Okay. Remember IL-12 here also. Suppose you have and suppose TH17 is not working, obviously more fungal infection. Suppose TH1 is not working, more granulomatous infection like TB or fungal. Those other fungals, intracellular. Suppose there is a persistent antigen stimulation and body needs to tackle this antigen through antibody. So antigen presenting cells secreting IL-6 and IL-21, combination of 6 and 21. So naive T cell converted into the T follicular helper, and T follicular helper cell is helping the B cell to create antibody. So this is a humoral pathway. What is a polarizing cytokine of T follicular helper? IL-6 and IL-21. What is effector cytokine from T follicular helper? This is IL-21, IL-4. Suppose some allergic antigen is here, then the antigen presenting cells secreting IL-4, which polarize the T naive T cell to the TH2, and TH2 starts secreting IL-4, 5, 13, and IL-10 that creates the IgE antibody and fights the allergy. So if you know the combination, and suppose there is infection, antigen comes, antigen has been tackled. Now we want the resolution of antibody. So antigen resolution of immune system. So antigen presenting cell starts secreting only TGF beta and IL-2. So this naive T cell will convert it into the T regulator cell. This T regulator cell inhibits the TH1, TH2, TH17, and everything. So all these things are the cytokine based. Okay. Same thing. I will go a little fast in this. First, what I told you, this is antigen presenting cell. Some antigen is here. That antigen has been chopped inside the cell, presented to the T cell through MHC2 molecule. This is the MHC2 molecule. This is target antigen. This is T cell receptor. This is signal one. Then co-stimulation is there. That is signals two. So you can inhibit the co-stimulation here also. That is known as abatacept. Okay. Then there is a cytokine that is known as polarizing cytokine. So what is happening? This cytokine will attach to their receptor. Then in the downstream, they are using some molecules, intermediate molecules, then the transcription factor, then polarization. So suppose in the malleoli near environment, this cytokine combination is there, IL-12 and interferon gamma. Then the master gene regulator T-bit will start forming and then cell converted into TH1. What is the function? Macrophage activation, cell-mediated immunity. Suppose IL-4 is there, then the transcription factor is the GATA3, polarizing cytokine, polarizing cell is TS2, humoral and eosinophilic allergy. Similar, if you have a combination of IL-6, TGF, beta IL-23, the polarizer will be the TH17, that is named the neutrophilic inflammation and barrier immunity. That's why barrier immunity, that's why this pathway is also important in the Behçet disease and IBD. Suppose you have TGF beta, then this cell is a T regulator, and this is known as immune tolerance. IL-6 and 21, T follicular helper. You just see what are the polarizer required for the TH17. So if you have TGF beta, which is an anti-inflammatory cytokine, plus IL-6, which is an inflammatory cytokine, so it's a combination of anti-inflammatory and inflammatory cytokines. So it's start differentiating into TH17. Suppose this TH17 got IL-23, so this got stabilization. So if you have a combination of inflammatory and anti-inflammatory cell, the resultant will be TH17 cell. But suppose you have only TGF beta, then it is anti-inflammatory cytokine, resultant cell will be the T regulator. So this is there. So autoimmunity regulation is there. As I told you, in rheumatoid arthritis, predominant pathway is TH1. In SLE, T follicular helper. In psoriasis, it's TH17 pathway. In multiple sclerosis, predominant TH1, systemic sclerosis, TH2, inflammatory pathway, TH17. So on isolated inflammatory pathway means spondyloarthritis group. And usually TH, if you say adaptive immunity, you can say like this, first response is TH17 or persistent TH17, that is innate, or TH17 followed by TH1. Okay. Then target. Suppose you want to decrease the TH17 polarization, so you can block the IL-6, that is tocilizumab. That doesn't mean why it's not helping in the spondyloarthritis. I will discuss later. Suppose spondyloarthritis culprit is IL-17, you want to block that, that will effective in spondyloarthritis group, secukinumab, ixekizumab. IL-23 is help in the maintaining TH17, ustekinumab, risankizumab. Co-stimulator inhibitor, abatacept. Downstream pathway, in the downstream, you are seeing a different path. I will show you can inhibit the JAK pathway. So point is that we will see the stat also. To T cell polarization needs a combination of cytokine that is known as polarizing cytokine. Then it uses some transcription factor. So that is important. As transcription factor is written here, it's known as a master gene regulator. And you have a different stats also. Okay. So now go to the classification of a cytokines. So what is important for us? We important for us to know cytokine classification through cytokine receptor. So we have type 1 cytokine receptor, also known as hematopoietin receptor. Type 2 cytokine receptor, which is known as interferon family receptor. Type 3 is third type is a TNF alpha receptor. Fourth is a in IL-1 receptor, which is more like innate immunity. Then IL-17 is a different receptor, which is totally different, not in this pathway. And then we have a chemokine receptor, which is a G-coupled receptor. So this is here. So type 1's receptor is using downstream JAK, either JAK1, JAK3, or type 2 receptor, they are using downstream JAK1, TYK2. So this is very important. So in both pathway, you are using Jack in the downstream. What is coming in the type 1 receptors? In type 1, many things come. You just remember it is not covering IL-1, TNF alpha, IL-17. That is important. So a type 1 cytokine receptor doesn't a receptor doesn't work through IL-1, TNF alpha, IL-17. All three are pure in it. What you have to remember, IL-6, IL-12, 23 is working through this pathway. Okay. Cytokine interferons is also working through JAK-STAT pathway. So once the interferon binds, they dimerize, then leads to the STAT dimerization, then transcription. What is the difference between two? You have some amino acid sequence which is conserved outside. Here you have no amino acid sequence there. And here is a JAK1, JAK3, here is a JAK1, TYK2. Major function, as I told you, type 1 pathway is a polarizing pathway of TH1, TH17. That's important. Even TH4 also. So different polarizing cytokine can be inhibited by the JAK type 1 pathway. Type 2 is an interferon, which is a key part for the connective tissue disorder. So JAK pathway can work here also. Now come to the TNF receptors. TNF is working through different way. TNF is working through TNF receptor. We will see in a detail. Downstream nuclear factor kappa beta pathway. Nuclear factor kappa beta leads to the IL-1, IL-6, TNF alpha, different inflammation, and caspase pathway leads to the apoptosis. So it's involved in the inflammation, not only inflammation in the cell survival also. So it's involved in the cell survival, inflammation, apoptosis, and lymphoid organ development. IL-1 pathway is a toll-like receptor pathway, that is 4. So IL-1 pathway is working through MyD88 and downstream it is working through IREC and different things. So JAK is not working in TNF, JAK is not working in IL-1. IL-17 is working through ACT1, ACT1 pathway. ACT1 pathway is downstream again through they are secreting nuclear factor kappa beta and different things. And here through intracellular calcium and cyclic AMP or ZMP, this pathway is working. So we have seen the different cyto properties of the cytokines, then classification of a receptor, then polarizing cytokines, then different T cells. Key home take home message is that TNF receptor dictates the downstream pathway. So if it is a type 1, type 2, JAK inhibitor can work. If it is TNF, IL-1, IL-17 pathway, then JAK will not work. That doesn't mean कि JAK inhibitor is not, I will explain later, but IL-17 per se is not working through JAK. This is very important and confusing also. Okay. Then the second thing, JAK-STAT pathway is working through type 1 and type 2 receptors. Type 1 means cytokine, type 2 means interferon receptor. Nuclear factor kappa beta is a common downstream pathway for TNF alpha, IL-1, IL-17. Then this yeah, understanding through which pathway you can see where Jack will come, where my D88 will work. Okay. So again, this is the same thing. I don't want to repeat this, but just only one thing. IL-6, you can block the IL-6 through tocilizumab, through olakizumab, and different IL-6 or IL-6 receptor. Okay, so this is IL-6 receptor family, which is coming under class 1 cytokine receptor. Okay, IL-6 is important for the polarization of the TH17 along with IL-23 and TGF beta. IL-6 alone or along with 21 differentiate T follicular helper cell. Okay, this is IL-1 beta inflammasome pathway. This is very important. Then TNF alpha, then IL-17, everything. Now, last thing about the antibody. So you know it's a Y-shaped structure antibody. The part of antibody which binds to the antigen is known as FAB region. This is the FAB region. And that this part known as FC region, crystallized region. So once antibody binds to the antigen, FC region becomes activated. So we want to know what FC region, how FC region creates inflammation. So once Fc region becomes activated, it can act through Fc gamma receptor, leads to the opsonization and damage. That is known as one pathway. So if you create an antibody binds to the antigen, then antigen antibody complex becomes activated, and that Fc portion becomes the ligand for the Fc receptor that leads to the phagocytosis. Same pathway. you can stimulate the natural killer cells through Fc receptor 3. So this natural killer cell will secrete the granzyme perforase and leads to the cell death. This is known as ADCC, antibody dependent cellular cytotoxicity. This is cellular cytotoxicity. This is not phagocytosis. What is happen? Antigen antibody complex, then FC portion becomes activated. That leads to the activation of the natural killer cells. Natural killer cells secreting granzyme and perforins and damage the cell. This is known as ADCC, antibody dependent cytotoxicity. So antibodies can lead to the ADCC. Antibody metabolized through phagocytosis. Then antibody once bind to the antigen, and then antigen antibody complex can be activated through FC portion, which stimulate the complement. So once the complement activated, this is known as classical complement activation. They can insert the pore membrane attacking complex and leads to the cell death. This is known as ADCC, antibody dependent cytotoxicity. So I just want you to remember two things: ADCC and CDC, complement dependent cytotoxicity or antibody dependent cytotoxicity. That is the two main method through monoclonal antibody leads to the damage of that cell. Then this immune complex can stimulate the different immune cells like neutrophils, like other granulocyte, like mast cells. So antigen antibody complex can leads to the clearance of that antigen through phagocytosis. That is a method for the metabolism of antibody. Then antigen antibody complex can stimulate natural killer cells. That is a method of a cellular killing through a cell. That is known as antibody dependent cytotoxicity. Antigen antibody complex can stimulate complements. So that is known as antibody dependent complement activation to CDC, complement dependent cytotoxicity. Third, fourth, fifth is here. Sorry, fourth, fifth, sixth. This pathway, antigen antibody complex, can stimulate granulocyte that leads to the secretion of the different granules and different enzymes and reactive oxygen species. So antigen antibody complex, if you're in your body, you have pathological antigen antibody complex that can leads to the activation of the different immune cell and different immune pathway. So this FC portion is important. Okay. Now immune complex, just little bit, although it's not important here, but this SLE is a disease in which you have a multiple antibodies. So these antibodies bind to the antigen and forms antigen antibody complex. That complex leads to the various injury. There is various type of hypersensitivity reaction. We will discuss later. But this complex is also important to understand the ANCA vasculitis, SLE, autoimmune hemolytic anemia, glomerulonephritis, good pasture syndrome, different things. Hmm. Then biological drugs. Now comes to the main topic. First, I just want you to remember some general rules regarding the biological medications. So biological medications, like the name infliximab, adalimumab, golimumab, that where this name comes. Okay, what is the importance of these names? Can we predict anything through these names? So the structure of a nomenclature of a biological drug is like there should be a prefix. Prefix means no meaning. We don't know why this is there. Then there should be a target substem, means there should be something which is mentioning your target. Okay, target substem, we will see. Then what is the source of that monoclonal antibody? So that is known as source substem. Then suffix. Suffix like suppose there is a monoclonal antibody. So this is known as MAB. Suppose you have any receptor, artificial receptor, that is known as sept, CE, just like a etanercept. Okay. So let's prefix, we know there is a no meaning. Suppose in the target substem, you find a word li, such as infliximab. Infliximab has a word li. Adalimumab, it has a word li. Tocilizumab, it has a word li. Okay. Golimumab, it has a word li. Li means low immunity. So anything which is creating low immunity, you can predict through the nomenclature. So if in a substem you got li, means target is immune system. Example, adalimumab, tocilizumab, ustekinumab. Okay. Then Ki means interleukin, means it is inhibiting interleukin. Okay. So sicukinumab, here you are seeing the Ki. So it's an interleukin inhibitor like IL-17. Ustekinumab, it is a 12/23 inhibitor. Risankizumab, That is a IL-23 inhibitor. Okay. So, and suppose if you have a word of CI in any drug, then it's work in the circulatory system. Some coagulation pathway, non-coagulation pathway, such as in a cardiology, we are using epsiximab. That is a antiplatelet drug. Suppose our biological medicine has a word TU, two. Two means tumor. Okay. So such as very classical example is rituximab, which is meant for, which is actually invented or initially first prescribed for the different kinds of lymphoma. Okay. Suppose you have a word like VI. VI means virus. So pelvizumab is an anti-influenza monoclonal antibody. Suppose you have a word of NE. Ne means nervous system, such as ernumab, which is used in the migraine. Okay. Suppose you have a word of S. S means skeletal system, like donesumab, which is working in osteoporosis. Suppose you have a word of TA that denotes to toxin. So rexibecumab. So these are the different words. So LI means low immunity. For rheumatology, what we should remember, or kind of we should have idea. LI means low immunity. KI means cytokines. TU means tumor. Okay. S means skeletal system. Then this is the target subsystem. Now go to the source subsystem. In the source subsystem, and why this is important. Suppose you have XI. XI means chi. Chi means chimeric. Chimeric means mixture. There is a Greek god is there which has a different faces of different animals. That is known as chimera. No? So suppose you have an antibody which has human part and mouse part, almost equal, 50-50%. That is known as chimeric antibody. So any biological drug which has a XI, that is a chimeric, such as infliximab. So it's a chimeric antibody, not fully human. So once you give into the human, there is a chances of anti-drug antibody because there is a non-human part also in this antibody or antigen. So why this is important? Ki XI, if you see XI, you can say, okay, anti-drug antibody can be more. Suppose you have ZU, ZU. ZU means humanized. Mostly human antibody, only some complementary determining region, which is a binding part, that is from the mouse. So those contain moderate risk of immunogenicity, that is such as tocilizumab. Zoo is humanized. It is not chimeric. It is not human. Okay. MU means fully human, or U means fully human. Okay. So adalimumab, golimumab, all these are fully human antibodies. So chances of anti-drug antibody is less. So I just told you all these things and suffix. Now the comes to the suffix part. Suppose you have a mab. Mab means monoclonal antibody. Many examples are there. Then sept. Sept means receptor. RECEPTOR. So they took the sept CEPT word. So suppose you created a biological drug which is nothing, which is just an artificial receptor, which is blocking the culprit cytokine. So that drug is such as etanercept. Etanercept is not a monoclonal antibody. It's a, you can say, monoclonal receptor, you can say, or fusion receptor. Okay. Such as abatacept. Abatacept is a receptor for CTLA4. Okay. And keen word, if you enzyme inhibitor also eculizumab, some words are like a monoclonal antibody, words are there some. So these are the rough idea of a nomenclature of a biological medicines. Okay. Then come to the TNF, tumor necrosis factor alpha. Tumor necrosis factor alpha, why the name come? Because in days, in during the experiments and 60s and 70s, they found in the some cancer cells, some hemorrhage was there. So some necrosis was there. So they just want to know what is the chemical. So they thought there is some chemical which is creating necrosis. So they gave the name of TNF, tumor necrosis factor. Okay. So TNF is a tumor necrosis factor. It is in the three form. We have TNF alpha and TNF beta. So TNF can be in the monomer form, but monomer form is not active. Okay. So with TNF monomer, each monomer made of 17 kilodalton. This is not active. So it has the intracellular C terminal and extracellular N terminal pathway, N terminal receptor domain. What is active form? Active form is a trimeric TNF alpha. All 317 kilodalton TNF alpha monomers becomes a trimer, then this becomes active. So these are the identical molecules. They are the functional cytokines, and these are the cytokines which bind to the receptor. TNF alpha can be soluble, means circulating to the circulation and exerting autocrine action, paracrine action, endocrine action, and it can be cell bound also. So this is known as membranous TNF alpha. This is known as soluble TNF alpha, which is creating the solubility TASE, TNF alpha converting enzyme. This is known as ADAMTase enzyme. So ADAMTase enzymes cuts this extracellular pathway, and this soluble form is free. So what is the structure? This is the TNF alpha intracellular cytoplasmic part. This is present on the most of the immune cells like macrophage and T cell, and this released through the activation of the TASE enzyme. So TASE is a membrane metalloproteases that cleaves the membrane bound TNF alpha and generates the soluble TNF alpha. It regulates the balance between local and systemic form. Inhibition. So suppose you inhibit the TASE level. So soluble level will be less. So some clinical implication is also there, but still now no medication has been made for the TASE. So I told you TNF alpha is not working through class 1 cytokine receptor, class 2. It has its own receptor. So they have two kind of receptor, TNF receptor 1, TNF receptor 2. This is very important. TNF receptor 1, it expressed in almost all nucleated cells, all the nucleated cells, immune cell, non-immune cells, everybody has TNF alpha because TNF alpha also has a survival signal. So TNF alpha receptor 1 present in each and every cell. That is for the proliferation and survival. Okay. So it contains the proliferation, survival, and respective death. It contains the death domain also, which means this is a receptor, this is a extracellular pathway, this is a transmembrane, this is a cytoplasmic pathway, and this is a death domain, and this is a cysteine binding domain, TNF binding domain. So they have death domain. They can create the apoptosis, then can create the survival signal. They present an immune and non-immune cells. They are not very important immunologically. So signaling pathway, they work through the downstream pathway that is TRAD, TRAF, we will read in the immunology class. And finally leads to the nuclear factor kappa beta, which leads to the inflammation and gene excretion. And through death domain, they activate the caspase and cell death can occur. So major function, it's a pro-inflammatory cytokine production, endothelial leukocyte recruitment, induce the apoptosis, and septic and in other forms also. So, but TNF alpha is present in both immune and non-immune cells. But TNF alpha receptor 2, which is also known as P75. Okay. This is present on the immune cells, such as T cell, T regulator cells, natural killer cells, endothelial cells. They don't have a death domain, so no apoptosis. Okay, here we in the TNF alpha receptor 1, you have a death domain. This is P55, this is P75. Death domain, no death domain. They also recruit the TRAC pathway, nuclear factor kappa beta. They work through canonical pathway, non-canonical, both classical and non-classical pathway. Promotes the cell survival and signal. So they are important in the immunomodulation, tissue regeneration, repair, T stimulation, proliferation. So these are the TNF alpha. So first thing, TNF alpha is a membrane bound and soluble form both. TNF alpha converted to the soluble form through TASE enzyme. TNF alpha monomer is inactive. Dimer is inactive. Trimer is the active form. We have two receptor, P55 receptor, P75 receptor. P55 receptor, immune, non-immune cell both. P75 receptor, it is in on the mainly on the immune cells. Okay. Function of a TNF alpha. So once TNF alpha binds its receptor through downstream pathway, they stimulate the various transcription factor. The transcription factor goes inside the nucleus and they promote the synthesis of various molecules like adhesion molecule. So TNF alpha through its receptor on the endothelium enhance the expression of adhesion molecule that leads to the inflammation. They increases the, because of the endothelial cells become activated, they stimulated the adhesion molecule. That is one. Endothelial cells become activated, they retracted and increases the vascular permeability. And because there is an increased vascular permeability, they recruit the neutrophils and different immune cells at the site of inflammation. So TNF alpha is very important for inflammation. That is one. Through its endocrine action, it goes to the hypothalamus and increases the body temperature. That's why it causes fever. Through endocrine action, it goes to the liver and stimulate the CRP protein and serum amyloid A and fibrinogen. This is second pathway. Third, it activates the different immune cells because TNF receptor 2 present in different immune cells. So they enhance the macrophage dendritic cell antigen presentation, different cytokines. Because they stimulate the macrophage, they help in a granuloma formation. So TNF alpha is very important for the granuloma formation. And I told you TNF alpha is principally secreted from TH1. And TH1 pathway is for the TB. Suppose there is a TB bacteria here. So through TH1 pathway, more there are abundant TNF alpha. That TNF alpha stimulate the macrophage, and that macrophage created the granuloma. And suppose you give the TNF alpha inhibitor here. So no TNF alpha, no granuloma, then there is a dissemination of TB. The fifth part is granuloma is important. Sixth, chronic TNF alpha can cause muscle wasting. Okay, they use the immune system, so more machinery towards the production of more immune molecule rather than the proteins. They can cause the apoptosis and cytotoxicity mainly through receptor 1, and they can cause septic shock. How is the septic shock? Because septic shock mainly through gram-negative bacteria. Lipopolysaccharide is there. Lipopolysaccharides leads to excessive TNF alpha. Excessive TNF alpha comes to the circulation. In circulation, they stimulate endothelium cells very badly. There is a endothelial retraction, lots of permeability there. BP drops, and that leads to the sepsis. So this is a normal function of TNF alpha. So TNF alpha is a pleiotropic cytokine because it acts on the T cell, it acts on the endothelial cell, it acts on the various other kind of the T cells, natural killer cells, and immune cells. So clinical importance of a TNF alpha, excessive TNF alpha, if there is a more TH1 pathway. So, and some TH17 cells are also secret. So in different autoimmune diseases like rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, inflammatory bowel diseases, juvenile idiopathic arthritis, non-infectious uveitis. So we can target the anti-TNF drug. So we have different drugs. We will discuss that. Major benefit, you reduces the local inflammation. So structural prevention is also there, and functional quality improvement is also there. Adverse effect, we will discuss in a separate slide. What are the adverse effects? This is very logical. Okay. Then special consideration, if you are planning to give TNF alpha, you should not give live vaccination during the TNF alpha therapy because live vaccination can lead to the infection. So killed vaccination is important. Pregnancy generally considered safe, but however, use in the pregnancy should be taken on the basis of the risk-benefit ratio. And we have to stop with surgery now, with surgery and all the other things. And I told you it's a biological drug, so our body can create the anti-drug antibody can lead to the less efficacy of a TNF drug. So we can combine it with methotrexate. So now TNF alpha summary, simple thing, structure wise I told you monomer 70 kilodalton, trimer active form 11 kilodalton, membrane bound, soluble form through TACE inhibitor. Two receptor, one is receptor present in everywhere, two receptor present on the immune cell, one receptor has a death domain, two receptor doesn't have a death domain. Okay. Then third is a action. It can create inflammation, fever, activation of the immune cell, apoptosis, granuloma formation, septic shock, cachexia. What I want you to remember, granuloma formation, you have to remember. Then apoptosis, you have to remember. So it is important for the apoptosis. It is apoptosis and granuloma formation. That is important. Okay. Then a clinical implication I told you, we will see for them. Then comes the TNF alpha receptor inhibitor, inhibitor. So TNF, it works through its receptor. So we can block the TNF itself. We can block the receptor. We can create the receptor which clears this TNF molecule. So produced mainly by the T cell, natural killer cell, and mast cell. Two forms I told you there. Pathogenic role I told you there. The role of inflammation, it is also clear. Then what are the classes? In TNF inhibitor, we have pure monoclonal antibodies. So what are the monoclonal antibodies of TNF inhibitor? We have three monoclonal antibodies of TNF inhibitor: infliximab, adalimumab, golimumab. All these are antibodies against TNF alpha, not TNF beta. That is one. And then fourth drug we have pegylated. Pegylated means only antigen binding side of antibody is known as Fab. So this monoclonal antibody biological drug have Fab domain. Then instead of FC region, we have pegylated form. So in this way, we don't have FC portion. We only have Fab portion. So there is no ADCC, no CDC. So cytolizumab is kind of squanger rather than direct inhibitor. Na? Then we can have artificial receptor. So that can block the circulating TNF alpha or bind or membrane bound TNF alpha. That is known as Eterna sept for receptor. So we have three monoclonal antibody, adalimumab, infliximab, golimumab. We have one receptor construct that is known as etanercept. We have one pegylated molecule that is known as certolizumab. So all these monoclonal antibody we have in our India. We have etanercept in our India, but we don't have certolizumab till now in India, at least as per my knowledge. Okay. So mechanism of action, I told you here, same thing, downstream pathway, same thing, no need to read it again. Then pharmacokinetics, monoclonal antibody. Monoclonal antibodies are the protein molecules. So you can't give it oral. If you give it oral, then digestive system will digest it. So we have two parenteral routes, either subcutaneous route or IV. Okay. IV IV route, if you are using IV route, profit is there. We have 100% bioavailability. Okay, but problem is there patient needs infusion. The patient needs admission for this. Then we have subcutaneous dosing. So you just give subcutaneously. It is absorbs through lymphatics and bioavailability complete incomplete. Here it is 100%. Here it is 80%. And there is a different Tmax, different days. For adalimumab, it's 3 to 5 days. For etanercept, it's 2 to 4 days. For certolizumab, it's 2 to 3 days. Then golimumab, 3 to 6 days. Then distribution. This TNF inhibitor is a albumin bound. So it's distributed in the volume, not a vascular space and in interstitium, not inside the cell. What I'm telling you, TNF inhibitor will present only outside the cell in the vascular space or interstitium, not inside the cell. So volume of a distribution is mainly plasma distribution, not inside the cell. Okay, this is distribution. Then metabolism. TNF inhibitor is not metabolized through liver or kidney. I told you this is metabolized through reticuloendothelial system. How it's metabolized through reticuloendothelial system? This is a method. What a first method. Our monoclonal, suppose adalimumab. Adalimumab binds to the TNF inhibitor. Then adalimumab and TNF inhibitor bound. This TNF is blocked. Then how it will be metabolized? Then some neutrophil will come through Fc receptor. It will phagocytize this and digest it. So method is reticuloendothelial system digest TNF inhibitor, not liver or kidney. Okay. Then half-life. Infliximab has half-life of 10 days. Adalimumab, golimumab, certolizumab 14 days. And etanercept has shortest half-life 3 to 5 days. Immunogenicity. Suppose you are using chimeric molecule, more immunogenicity. So with infliximab, there is more immunogenicity. How will you prevent immunogenicity? You can, what we have seen through different trials, if you are giving biological drugs along with methotrexate, you can prevent immunogenicity. Body weight, according to the body weight, some drugs like infliximab, we are giving according to the body weight. Then on the basis of serum albumin, suppose you have less albumin, then then the blood will be less on the circulation, so less effect. All these are the parameters. Okay. Then clinical implication, I told you it's this indicated or approved in RA, ankylosing spondylitis, psoriatic arthritis, inflammatory bowel disease, juvenile idiopathic arthritis, non-infectious uveitis. These are approved indication, FDA approved indication. Non-FDA approved indication that it can also use in sarcoidosis. Okay, it can also use in Takayasu arthritis. In sarcoidosis, but one thing you have to remember, etanercept is not going to helpful in sarcoidosis. Second, uveitis, etanercept is not good for the uveitis. Okay. Then available formulation, IV formulation for infliximab, all other are available in subcutaneous formulation. Even golimumab also is coming in IV formulation also. Onset of action usually 1 to 2 weeks. Okay. For what investigation we should do? We should rule out TB because I told you TNF alpha is important for the granuloma. So once you give the TNF inhibitor, then granuloma will melt, then the TB dissemination can occur. So we have to rule out is there any TB infection. So IGRA testing, Montox testing, chest X-ray we are doing. We are clearly eliminating any chronic infection like hepatitis B or HIV. Or so we are doing the routine investigation along with this viral marker or TB workup. Okay, adverse reaction. We will see in the one slide, one way. Adverse effect. Okay. What is TNF inhibitor? Obviously, immune system is less, so chances of infection is more. Which part of infection is more? More intracellular infection. So more fungal, more granulomatous infection because TH1 pathway is inhibited. So more chances of TB, fungal reactivation, some bacterial infection, viral infection. Okay. I told you TNF1 receptor has a death domain, which is important for the apoptosis. Apoptosis is the programmed cell death. Suppose you are not having programmed cell death, so chances of malignancy is increased. So there is a chances of lymphoma, non-melanoma skin cancer, and other malignancy. Then there is a, because you are giving TNF inhibitor, so you are suppressing one part of inflammation. So immune system can overactivate in some other pathway, not in TH1 pathway, in different pathway. So suppose TH17 pathway is overactivated, so you can have psoriatic kind of paradoxical reaction. Suppose T follicular helper pathway is more activated. So SLE corrective lupus like side effect can also occur, and demyelination is a serious side effect. So what I just want you to remember, it can cause autoimmunity also. Although it's an immunosuppressive drug, but autoimmunity can be the part of TNF inhibitor therapy, such as anti-drug and anti-DHDNA antibody, SLG, serositis. Okay, it usually resolve after stopping the drug. It can cause the cutaneous vasculitis or ANCA vasculitis very rarely. Okay, it can cause the demyelination like multiple sclerosis, optic neuritis, and different antibodies can be positive. If you are giving in an infusion, then infusion reaction can occur, anaphylaxis can occur, and subcutaneous site reaction can also occur. Hematological. Okay, TNF inhibitor is also important for the lymphoid development. I told you in the beginning part, and some part with along with the other cells, it also help in the bone marrow environment. So it can cause different cytopenias or anemia. TNF inhibitor is contraindicated in the heart failure class 3 and class 4. In a serious liver infection, it's also it's all in I told you ki in hepatic side effect can also occur, neurological side effect can also occur, dermatological. I also told you ki it can cause psoriasis type of skin reaction. So important consideration regarding the TNF therapy. I told you it is important for the granuloma formation. So if you are giving TNF inhibitor, there is a breakage of granuloma. Breakage of granuloma can lead to the dissemination of the granulomatous infection, such as TB. Okay, chances of the highest risk with infliximab, lowest risk with etanercept. Second thing, difference between drug. Etanercept is a fusion protein that is working on the, and that is what is a receptor. Etanercept is a receptor. Which receptor? TNF receptor 1 or 2? It's a 2. So it will block both TNF alpha and TNF beta. It's not blocking the granulomas effectively. So it's relatively safe in risk of TB, and it is ineffective in sarcoidosis. Okay. Monoclonal antibody, they are working through ADCC and CDC, antibody-dependent cytotoxicity, complement-dependent cytotoxicity. Here, no ADCC or CDC. And certolizumab don't have FC portion, so no ADCC or CDC. Placenta is a Fc gamma receptor. Monoclonal antibody is a IgG antibody. So monoclonal antibody can cross placenta. So this is another important thing. If there is a chimeric drug, you can have anti-drug antibody. What is paradoxical reaction? Means you are giving immunosuppressive drug for the autoimmunity and patient developing autoimmunity. That is a paradoxical reaction. So patient can develop psoriasis form reaction, patient can develop lupus-like reaction, patient can develop demyelination and different things. Okay. And malignancy, I told you, demyelination, I told you, heart failure, I told you. So these are the there. Then I have almost discussed everything regarding this. Just infliximab, one thing, it's used per kg body weight. Dosing is from 0 2 week, 6 week, then followed by 2 monthly. Okay, infusion time is over 2 hours. Maximum chances of TB reactivation. Okay, chances of anti-drug antibody. This is the first monoclonal antibody among the TNF inhibitors. These are the different trials which, but I just want to go through the name of ATTRACT trial. It proves the efficacy in RA. ASPIRE trial in early RA, ASCENT trial in the IBD disease, ASSERT trial in ankylosing spondylitis, and in psoriasis. So these are the different trials for the infliximab. Infusion reaction, you have to remember up to 20% in can occur. With a subsequent infusion, chances of infusion reaction is less. In first infusion, you have to give in 4 to 5 hours. Then subsequently, slowly you can decrease the timing also. On all these side effect I told you, infliximab, same thing. For the adalimumab, also adalimumab, it's coming in the 40 mg subcutaneously. Once in a 2 week, we are giving. Infliximab is a per kg body weight. Etanercept strength is coming 25 mg or 50 mg. Even golimumab is also coming. I think with this, my presentation is over. Uh, uh, Hello.
Yes, sir.
Rin, my presentation is over with this. Any
Okay.
question is there?
Thank you, sir,
Hmm.
for this excellent session and
Thank you.
for sharing this valuable insights with us. And no doubt, as always, The session was quite informative, and such advanced concepts you have made us so easy and very easy to understand, whether you are discussing such complex mechanisms, some such complex pathways, or whether you are discussing decoding such complex nomenclatures. So that was quite interesting for us, and it was very remarkably and easy to understand. So
Thank you.
thank
Thank you.
you for your expertise, and it was a very nice session, sir. So thank you from all of us. Now, just let me check the questions if available. So there are a few questions. Uh, what factors affect absorption of biologics like TNF inhibitors?
Such as we are giving subcutaneous, okay, and IV infusion also. IV infusion, I told you 100% bioavailability is there. But problem is that patient have to admit in the hospital for 3-4 hours or 5 hours. And this is not very practical in the day-to-day practice if you are giving monthly basis. Then in subcutaneous issue is there. Suppose patient's albumin is very less. Patient is cachexic. Our patient is having some infection, chronic autoimmune disease. Albumin is also less. And I told you the T half will depend upon the albumin because the TNF inhibitor will not come inside the cell. It reside in the plasma. So you need something to keep in plasma. One is albumin. If albumin is less, your half of efficacy will be low. That is one. Second thing, your in site of injection, because I told you subcutaneous. Why subcutaneous? Through subcutaneous, lymphatics should absorb this. Through lymphatics is will directly go to the reticuloendothelial system and will start creating its anti-inflammatory action. But suppose you inject accidentally in some muscular areas, or there is a some less subcutaneous insertion is there, then although you have given parenterally, but there was no lymphatics to absorb that. So site of injection is important. To wherever you have a more some fat, because fat means definitely you can, fat is a base. Above that subcutaneous is there. You can easily put on the fat because base is there. So in the tummies and here and there, we are advising the patient to keep. And second thing, all the pens are coming in these days for golimumab and other some
Right.
pens are. So some patients they start taking by themselves, and this is very good also. But some patients are old and everything, so their technique is not good. They are just insulting, and half of the drug is discarded, and some way this is not very helpful for them. So
Mm.
this is also a thing for get less efficacy. So these are the different things which affect your bioavailability of a drug.
Right, sir. Thank you. So one more question. Sir, among FC mediated mechanisms like ADCC, complement activation, and immune complex deposition, which pathway plays most dominant role in rheumatological tissue damage?
Actually, this is very interesting and very deep question, and this is the basis of whole rheumatology. Suppose your immune complex is circulating in your whole body. That is known as type 3 hypersensitivity reaction. So if it is circulating, it will affect your multiple organs simultaneously, especially the filter organ like kidney and lungs. You have oxygen exchange, you have urinary exchange. So they will deposit there. In circulation, while going, they can damage your blood cells. So if you are having multi-system like SLE, this is a circulating immune complex. Okay, that is one. Suppose immune complex is not circulating, it is fixed somewhere. Like RBC, RBC has an antigen which is fixed. Then antibody comes and bound to the RBC. So that is known as local immune complex that will create local damage, means one organ autoimmunity or two organ autoimmunity. That is known as type 2 hypersensitivity reaction in which antigen is normal, healthy. Your body's antigen. But in SLE, antigen is DNA and RNA, which is not your antigen. That is inside the cell. Body has never seen DNA, RNA in the circulation. So this DNA and RNA is actually circulating in the blood, and antibody bounds disease, and they circulate together and they start creating type 3 hypersensitivity. And type 3 means, in simple words, I'm telling you, more than three organ. Type 2 means maximum two organ. Like that way you remember. So this is a very good question actually.
Okay, sir. So I think, sir, if any other questions are there, I'll request, please share us on in the comment section, and definitely doctor is available to give the question, to give the answers at all times. So I think, doctor, with this, we can just close, and thanks all the participants. And thank you once again, all the participants. Thank you, Dr. Tiwari. And once again, thank you. And we really admire you for successfully, you are leading such a good, initiative that you are taking for the continuous development and learning of the rheumatology. So we are very thankful to you from our core of the hearts, and from on behalf of all the participants. And we request you to please continue such series, and more participants will be joining, and we'll be soon sharing us the next the webinars dates. Okay, doctor.
One more thing I just want to tell here, I doesn't cover many things, which is for the classical rheumatological students, like different trials and those things. So those who are listening, I just want to convey them with a disease. As we progress, we will discuss everything in detail, but in a relevant sections. And because just finishing all those things in within a 1 hour, it's not humanly possible actually. So I am just taking all the conceptual points, just taking superficially. Once we go towards the disease, we will discuss this very in a very detailed fashion, and purely discussing each trial for 1 hour and 2 hour like that way. So just be patient for those who are listening, and I will cover everything from our standard books and articles. Okay, thank you so much.
Okay, thank you once again, all the participants. Thank you, doctor. And with this, we'll just close the session.
Thank you. Thank you.
Thank you, everybody.